You are listening to Lifeboat for the White Coat podcast. Welcome to the 5th episode of Lifeboat for the White Coat podcast. Today we are talking with Dr. Michelle Cooke, and we're very excited for her to be here. So thank you for coming and carving out some time for us, Michelle.
Absolutely. It's my pleasure. Thank you for inviting me.
Yeah, Dr. Michelle, thank you for taking the time this morning. I'm trying to remember back. Was it in Orlando that you and I met last year?
That is correct. Yeah, at the Nuts and Bolts conference in Orlando.
Okay. Yeah, and you're from Georgia. I was in Atlanta last year as well, but I don't think I saw you there. But we've seen each other maybe a few times since. So thank you for taking the time. It's been certainly great to get to know you a little bit. And I can tell you this, when I heard Michelle speak in Orlando, that was the first time I had met her, but it was one of the most, I guess your story to me was one of the most down-to-earth stories about a doctor being frustrated and a doctor finding solutions. And it had to do with what would seemingly be maybe what some might write off as simple things or unimportant things, but the name on the door and requests. And so I think your story is incredible, and I'm just excited to hear it again and to refresh.
Certainly. I've been trying to work on making it a shorter story, but I'll do my best to get the salient points, but make it still somewhat concise. But I'm a family physician. I absolutely love what I do. Went into medicine because you love connecting with people. I love that I can bring in, science and social science. I was actually a Spanish major, so even my passion for language and how to communicate, all of that I've been able to incorporate into medicine. And I finished residency in 2014. So at the time I was coming out, there was really no talk of private practice, direct primary care. Like that wasn't a thing. You get out, you get hired, and you just hope that things go well from that point forward. So it was never taught to me or an idea that I could have a practice. And I come from a pretty blue collar family. And so a lot of time that same message was there, you get educated, you go get a good job, and that's what you do for the rest of your life. And so this idea of entrepreneurship or having a practice just had never been in my mind. And so I graduated from residency here in Atlanta, and I opened a practice under a large hospital system in the Atlanta area. And like most physicians, I feel like things probably start well. The organization is investing in you, and they're getting your marketing, and you're getting patients. And before you know it, it just feels like you are flooded. At some point, it just got to a point where I just had more patients that I could really safely manage. And I felt like things weren't right. I'm like, the most important thing for a doctor to do is get a medical history and talk to a patient, understand what's going on with them. And that time just kept getting cut shorter and shorter and shorter. Mm-hmm. I remember when I first started, I had 20-minute appointments, like 20 and 40 minutes, which was wonderful for me. And then it got dropped to 15 and 30 minutes. I was like, you guys, 15 minutes, I really can't do a great assessment in 15 minutes. I knew it was unsafe. I knew it wasn't okay for me or for my patients, but it kept falling on deaf ears. Dr. Cooke, this is standardization. The whole system has to do it this way. In order for us to get what we're going to recuperate from insurance, it has to be this. And those were always probably my biggest gripes with the system, is that I was seeing too many patients, not enough time to give high quality care and to really make an impact. And then other things started picking up. They want you to see all these visits. You are most profitable for the system when your schedule is full, which often means that you lack access. So when my patients needed me the most, they couldn't get in. Every day I was sending people to urgent care. How interesting that the same company I worked for had an urgent care around the corner from primary care. Right? To kind of funnel off people. Well, they really need you. We're just going to send them to urgent care, and they'll see some provider that doesn't know them very well. And then when they say follow up with primary care, they can't get in for 2 to 3 months. And so the system just kept feeling broken. The other part of that story is, you go to medical school, you graduate from residency. That whole time you've kind of been the scut, right? You're used to kind of being in the trenches, doing what you're told, taking one for the team, having a horrible schedule. And you hit this realm of attendinghood that's supposed to be the promised land, right? You're the doctor now. You're in control. You get to call the shots. And increasingly, that just was not true. And so for me professionally, I was getting very frustrated. but also just not feeling like I had earned my own title, right? I had no control over my schedule. Schedulers had more control over my time than I did. When I would try to get breaks or ask for vacation, it became a big to-do. You mentioned my name being on the door. So the name on the door said Dr. Cooke provider. And I can't stand the term provider. I feel like it lumps everybody together, does not recognize the expertise of what it takes to become a physician. And we have different ranks in healthcare, not to put people in a hierarchy, but to recognize the special talents that people bring to this profession. And I feel like that was washed over. And I remember requesting, I was like, can we change my name to physician or to Dr. Michelle Cooke? And it never happened. It was, no, this is marketing issue. This needs a committee result. It had to go up and down the chain, like all this ridiculousness. So even my own title, which was very appropriate for the setting, couldn't even be reflected on the door. Another thing I talk about is we used to play music in the clinic that was apparently approved by admin, but oftentimes extremely inappropriate. So the two things I remember is like Marvin Gaye used to play and Sexual Healing would be playing in the background when I have like old ladies coming in for their visits. And I was like, this is so inappropriate. Can we change this? Another time we had funk music playing at 8 o'clock in the morning, giving me a migraine. I'm not even a headache person. And I was like, can we change this? Nope, Dr. Cooke, this is corporate approved. We have to listen to this. And so I say those things to say that each of those things feels really small, but in aggregate, you get to this place where there's so many issues and you can't even fix the small stuff. There's no way we could get to the big stuff. No way we could get to the big stuff. And so it just kind of felt like at every corner, I couldn't make any meaningful change to make my life better and to make life better for my patients that were seeing me. And then all of this came to a crashing halt in 2022. When the hospital system I worked for ended up collapsing in my community. So I live in a community of Southwest Atlanta. This is a large community. It's the largest Black community in Atlanta. There's a lot of historical significance of this community. Martin Luther King's home is not far from, it's actually down the street from the hospital where I trained. So very, very meaningful community. And suddenly all the care was going to be gone from this community. So my hospital system closed 2 hospitals and all the primary care clinics in this location. So it was a shock to the community. And what I say is that I don't know that we'll ever see the recovery from this in my lifetime. Like just the removal of that many doctors, that many facilities. They're actively tearing down the hospital as we speak. This institution that had stood for more than 100 years, where I delivered my baby, that trained, all these residents and physicians, is now gone. Serve the community, now gone. And so that was one of the worst days for me as a physician, but it also was the awakening of something new.
You are listening to Lifeboat for the White Coat podcast.
I had been kind of, lurking, as they say, the direct primary care community for a long time, thinking that direct primary care seemed amazing. It seemed like the way we were meant to practice medicine, but little old me, I'm just a doctor. I'm not a business person. There's no way I could start a DPC practice. I just did not feel like that was something I had the skill set to do. And then it kind of came to my front door because I was handed a termination letter saying, we're closing down these facilities. You can leave the community. You can go work at one of our other centers someplace else, but, the care is not going to be here. And where that was a turning point for me is like, no, I can't leave my community. So even though I'm not originally from Georgia, you said at the beginning I'm from Georgia. As a Northeasterner and an original Yankee, it's hard to call myself a Georgian, but this has been my home, right? I'm very proud to live here and be part of the Atlanta community and the Atlanta legacy. But this community of Southwest Atlanta had embraced me. This is where I went to college. This is where I went to medical school. This is where I trained. This is where my community is. And the idea of leaving them behind didn't make sense. What was also clear to me was that even though we were so busy, saw all these patients, were breaking our backs every day to give care, it was not profitable, right? Like that didn't make any sense to me, that how could we be seeing all these patients, like have all this demand, but somehow we can't stand up. So to me, that means that the business model doesn't make sense. There's corruption somewhere, like something doesn't make sense that we could be this busy and still be collapsing like this. So I just learned that our model's not working. And if I was going to stay in medicine, I had to do it differently. The idea of staying with the same organization to go to some other side of town, to still have my name as provider on the door and inappropriate music and playing throughout the office, just in a different location, was no longer desirable for me. And I was like, if I'm going to stay in it, I've got to be brave and I've got to do this crazy thing called direct primary care. So by the time I met you, Matt, that was actually my second nuts and bolts. My first nuts and bolts, I went to actually my last month being an employed physician. And just kind of to get that final nudge of like, is this really what I'm going to do? And I met all these crazy doctors who had a dream that we could do healthcare better and do it differently. And it gave me the motivation that I needed to go ahead and get my practice started. So that is the briefest way I can give my origin story, but I think that kind of lays the framework. And I'm happy to answer any questions or go deeper into some of the things I just mentioned.
I have some questions. I just remember you and I speaking not too long ago, and one of the things that I was very much impressed with, that you're connecting with your community through social media in a different way. And I will say, I don't see physicians, doctors doing that really. So I feel like you're connecting with people directly. Can you talk more about that? And what was your aha moment around getting in front of your community?
Oh my gosh. So you have to wear such a different hat when you are a business owner and an entrepreneur. And when you're in this thing called direct primary care, I mean, we're getting the word out. That's why I love doing things like this, because a lot of people don't know what it is, don't understand what it is. They're very skeptical about what it is. And so you have to kind of find platforms to share your message. As an employed physician, I didn't realize how much of the institution was doing that for me. You know, they've got the billboards all over town, like they're in the newspapers, they're sponsoring these events. And so I think sometimes doctors get this idea that like patients just show up to us, like they just come, not realizing there's this whole marketing engine that's behind us. So yes, you might be a great doc, but if you can't get the word out, it's likely that you're going to fail or you're going to have a harder time getting started. So I learned that I had to start speaking to my community a lot more to educate them about what was different about this model, the problems in their system, where we're being left behind, and that can start to change some voices. So as much as I enjoy social media as my own consumer, I never thought about myself being a content creator. That just seemed like a lot of work and a lot of fluff and just a lot of things I didn't want to get into. But I will say I've been able to make some of the greatest impact through my work through social media, and I'm actually really proud of it. And that's for several reasons. Number one, it has helped me build my practice because I'm able to speak to my community, get the word about what we're doing. So that's helped to build. On another level, I said I never wanted to be on TikTok. And then I learned that people get 50% of their health information from TikTok. And there's a lot of craziness out there, you know, people saying, you know, I don't know, infuse bleach to treat COVID. Let's not get too political. But anyway, things like that are out there, right? And so it's nice to be able to show up as a physician voice, as someone who has training, that has credentials, that can speak to these different things. A lot of people just don't have access to care. And I have women all over the country that say, hey, Dr. Cooke, my doctor said I didn't need a pap smear for another year. What's that about? Or, you know, I don't need to do a pap smear for the next 5 years. Is this legit? Am I being denied health care? And I can speak to these concerns. For women and patients around the country. We can do a lot of education. People have a place where they can go to where they can feel heard. Once a week, I do these TikTok lives and we talk about different health topics. I've been able to bring other doctors to join me on these lives to talk about topics that my patients are interested in. And every time we do it, there's always women that say, I have never seen a doctor that's looked like me be able to give this information. I've never heard someone talk about my fibroids or my urinary incontinence the way I felt comfortable to ask questions. So I feel like I'm able to deliver care at my practice here, you know, here in Atlanta, but also there's a space that we've created in social media and in the virtual world where I think more people can be seen. I think a lot of physicians shy away from it because there are some pretty harsh social media policies when you work for an employer. You know, they're like, you can't say this, you can't say that. And so it's really just very dangerous to come to social media because you could risk your job. And so I think we don't get to hear a lot of physician voices, which is really unfortunate because I think so many doctors have such an important story to tell that we could help connect with community. But many of these employed situations keep us very silent. And had I not had my own practice, I would probably be very silenced too. I really didn't go to social media prior to this because it's like, oh, I could say the wrong thing and there goes my job. Oh, that's not worth it. You know, I'm busy enough. You know, there was really no impetus to get me there. But for me, it's been a great, not only driver for my practice, but a great way to connect with the community, get people informed. You know, I have a lot of connections I've built through social media.
That's powerful. And you talked about a lot of things. I'd like to maybe just bring out some high points. I mean, first, I think you might have been the opening speaker that year I saw you. I'm not sure. You were certainly one of the opening speakers, if not and you just got my attention. I mean, I've been doing this for quite a while, so I know this game and I know the advantages of DPC, but you were really inspiring to me. And we just talk about the value. So that what kind of big insurance has done to healthcare and these labels that are placed like provider, right? I totally get why that's a big deal. I've never cared for the word, and I don't have a medical background, but then they label then the brokers as producers, which is like just as bad, right? But it shows their mindset: money, 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 and then just kind of really certainly not enhancing, if not lowering the morale of the most important people, the ones taking care of patients, and it's downhill from there. And then we go to patient panel size. One thing I would like to ask you about numbers. You didn't mention specifics. Can you give us an idea of just your experience and then even the time to code? Because I think a lot of that is lessened, right, in the independent world. Can you give us an idea of patient panel and what that means for the quality of care?
Oh my gosh, I'd love to. So I think one of the most important things I think to share is even with the large institution I was with and all the data they were collecting, every time I would ask for my panel side, they would not give me that information. Because I was like, I think I'm squeezed to my limit here. Like, how many patients do I have? Like, I never really even thought to think about that number until I felt very squeezed. And I'm like, how many patients is appropriate for a primary care doctor? And so I remember like going to AAFP, and of course there's not a perfect number. It's like, how much illness is in your community? Are you dealing with older patients, younger patients? So some of those factors will teach you a north or south. But everything I was reading was showing me that your panel size really should not cap above 2,000. Like if you're up there, maybe you're taking care of a lot of like young, healthy athletes, but like if you're above 2,000, you're probably stretched too thin. And before I left my institution, I was able to like dig through Epic and figure out that I had 3,000 people that were under my name as a primary care physician. And when I saw that number, it like everything made sense. I was like, it's clear why I feel like I'm drowning because this is impossible. And when I've asked to close my panel so that I couldn't take on any more, they're like, well, we don't really want to close a panel. Maybe this is time for you to bring on a nurse practitioner or a PA. And to me, that was not a good response because I was saying I need to close my panel because I'm at my limit, not that I'm ready to supervise somebody else to expand that panel even further, like that you're telling me to do more work right now. And I already feel like I'm drowning in that. And so it made sense to me. That's why I have no access. That's why when people call for an appointment because they're ill, they can't get in because they're competing with 3,000 other people. There's no way I could take sufficient care of all those patients. And to your point, it's a whole nother conversation. We can talk about it too. But yes, it's not just seeing the patients, but it's the billing, it's the coding, it's the, just all the paperwork that comes with that. There was a study, I want to say it was by University of Chicago, that said that the average primary care physician, in order to do like a baseline job to make sure everybody gets the preventive screenings that they need, documentation being appropriate, they need 26.5 hours a day. That's all, just 26.5 hours a day, right? And of course, their days are only 24 hours a day. So to me, it was clear, like all of us are falling short because we're set up to fail. And you can't make people be set up to fail day after day after day. Like there's no morale booster because you're always behind. So you're always taking shortcuts. Somebody always gets left behind. And many times that's patient. I can't listen to that second concern. I can't hear about your depression. I can't even get you in for your sick visit because we're so overburdened. Another thing that was happening because of those ratios is I feel like we were pushed to do care. I'm not going to say low value, but maybe unnecessary. So an example is Medicare physicals are very profitable and very valuable for healthcare systems. And so we were going to get these Medicare physicals on our schedule, like come hell or high water. So my day was booked with all these Medicare physicals, whether my seniors wanted them or not. We had this aggressive scheme of like, call them, get them in. We got to get those physicals, bill these physicals, upcode these physicals, double charge, like add modifiers, like everything we could do to squeeze every dollar out of this physical for a well visit. So on one hand, yes, it's good because we're making sure our seniors get their well visits, but it was always at the expense of people being able to access care when they truly needed it. So I might have 5, 6, 7, 8, a Medicare physicals in a day. And then when that mom calls because her baby had a fever last night, I'm sending them to urgent care. Or if someone's like, you know what, my blood sugar spiked this morning, I'm not feeling so great, what should I do? Or urgent care or hospital. So we really couldn't offer the value of primary care that made sure that people didn't get sick or need higher level services because we were so booked out with these visits that, again, I hate to say not necessary, but it wasn't the biggest priority. And so that's one way that we can show how insurance really, I think, disincentivizes the value of primary care, because we weren't flexing our model to give our patients what they needed. We knew what we needed. We needed the value from these Medicare physicals, regardless of whether the patients needed it or not. So that's where our focus went.
Yeah, we see that, right? It's almost odd to say it, but it's just in front of our eyes and all the conversations we have. You've lived it. The focus is on maximizing profits, not even really what the patient needs. Like you're saying, patient doesn't really know what they needed or even maybe need it, but we're going to do this. We're going to get them in here. It's a profitable thing. And then it pushes aside urgent care is around 3 times the cost. ER is around 5 times the cost. That's assuming that maybe upcoding isn't happening, which we know it does in almost every case. So all these games are being played at your expense, at the patient's expense, and enough is enough, right? So what would you say is a good patient panel size for a DPC physician?
So I think on average, we're seeing panel sizes between like 300 to 600. But what I like about DPC is that, again, going back to that physician autonomy, I think physicians have worked really, really hard. And I think that if you want to have more autonomy in your practice, DPC can provide that. And I say that to say every physician knows what they can handle, and for me, as you can see, I'm a talker. I want to talk with my patients. We spend a lot of time. I can't have a huge panel size. So I'm aiming for a panel size of about 300 to 350. Right now I'm sitting at about 250. So the practice is still growing. But there's some other doctors, I think about some of my Midwest guys, they're kind of like, let's get the problem in, get out, and they could probably handle a panel size of 600, 800 patients. And that works for them because in their community, it's like, we're going to do these quick touch points. We might meet more frequently, but, we're going to do these quick touch points and get your care taken care of. And that works for their model. So I think rather than forcing down this one size fits all for every clinician, the clinician can say, this is my practice style. This is how I'm going to really serve my patients best. For me, it was not in the 15-minute appointment. And I can make my panel size work for that. That way I can make the pricing work for that. Like you can really mold it to what works for the physician, which I think is going to give better care to the patient. The other thing is it gives patients more choice. I have some patients that don't want to see me. They're like, oh my God, that doctor's going to talk my ear off. I don't want to be at that practice. This is too much. I want that doctor that's going to be in and out. What's my problem? And get me on my way. And so they can start to kind of connect with the physician that works best for their practice style. And I call that getting more cultural concordance. When there's cultural concordance between the physician and their patient, the care is more optimized, because you're alike. The way that you see problems is alike. The way that you explain problems, the way you want to go about solutions is finally aligned. But I think in the system, they kind of create what they think the alignment should be, and it does not fit for everybody. So I struggle to say what's a good panel size because it really is going to depend on the clinician. It's really going to depend. And I think that's okay.
You are listening to Lifeboat for the White Coat podcast.
Yeah, that's a great answer. Instead of just some bland or generic figure, I think there are a lot of variables there, but it's to me seems to be centered around the patient, right? Which is what we did maybe 40 years ago,
Right.
which was how healthcare worked. Billing wasn't complicated, and it was based on the patient care and the doctor's uniqueness. And I think you're the first doctor maybe that's told me that they didn't even that you didn't even know your panel size. I mean, that's the first time I've heard that. Usually I hear 2,000, 2,500. Not only was yours higher, you had to research it yourself to find out. And just not respectful of, and MDs, and kind of shifts me to maybe the transitions to this third point of how I see MDs. So right, probably one of the toughest, most regimented programs in the nation, right? So tell me if you agree. I don't think you'll probably disagree, but like incredibly hard. Like, I don't know what percentage start medical school and what finish. I bet it's small. I bet there's a huge fallout. And so here we have big insurance, big hospital systems, oppressing, controlling, trying to make you cogs in a machine, in a money machine. And I always say, if that was a group I was going to try to oppress and mess with, that'd be the last group. And I love your spirit of, you know what, we don't come out of the womb, right? We're not born doctors or lawyers or right. You've learned those skills. We're also not born community leaders or entrepreneurs, but doctors can also learn those skills, and that's what you've done, and makes you kind of unique. Like Paul Thomas was there. He's going to be on in I think a week or two, something like that. He didn't even go into the hospital at first, which was one of the really rare cases, right? But he saw the writing on the wall, and he also leads his community, which was kind of at one time somewhat of a broken community, and they've really brought it back up in the Detroit area. So just really cool stories to see very talented people, MDs, become even more than MDs. How cool is that?
One thing that we've been talking a lot lately about is the public's interpretation of what direct primary care means, what it is, how is it different than concierge. There's a lot of vernacular that we use because we're in it, but that we have to do a massive paradigm shift in the patient population to understand that doctors like you exist and that they have the power to make these choices for themselves and their families. What are some ways that you're maybe changing the language when you speak to the patient population and introducing your style of care as opposed to what they receive in the hospital system? And do you have any advice towards that?
Absolutely. There's so much I have to say about that. And I think the first thing is not just educating patients, but even educating physicians. So I think I'm further ahead of my colleagues because we go to medical school to learn medicine, and then somehow we get dumped into the system that we're like, this seems absolutely nuts. Like, what's going on here? There's no transparency. And I say that because a lot of physicians don't understand how detrimental the system can be, how the lack of transparency, just the way that we harm people through the system. And I think physicians need to understand that. So what do I mean? I spoke to residents this past week about direct primary care. In the room full of residents, I said, you know what, how much does an MRI cost? And they're like, like maybe 500, 2,000, like nobody knew. You couldn't walk into any other business and ask them like what their prices are, and people can't tell you. But here we are in medicine, and we have no clue like what the work that we're doing and how it affects our patients. I shared the story about how when I was still in fee-for-service practice, I had an older patient who needed a pap smear. She was 65, just into Medicare, and she needed a pap smear done. And she just like, I don't really want to do a pap smear. I don't want a pelvic exam, like very shy. And I was like, you know what, Miss Jones, we really got to do this pap smear. I can't tell you that you don't have cervical cancer. We're not up to date in your screenings. And because she trusted me as her physician, she's like, all right, Dr. Cooke, let's do this pap smear. I did the pap smear. The clinical indication is to add an HPV test to that for women over 30. So that's like sound medicine. And this woman got billed $400 for that pap smear, $400, which for something I thought should have been a covered test. And somehow it wasn't because I added that HPV, and Medicare said, nope, that's additional testing. It's not clinically indicated. I sent my poor old lady into collections. So how much harm have I done because I couldn't give informed consent about what the pricing would be? That same pap smear in my practice right now is $88. So less than 75% of what Medicare charged for that. So we need to start showing stories of what happens when we don't have price transparency, and we're roping people into care that they truly can't consent to, and now we're financially harming them. We know the number one cause of bankruptcy is healthcare fees, and it shouldn't be that. And that's for people that have insurance. So if insurance is not protecting us from these catastrophic expenses, what is it really doing? I think we have to have that conversation. And a lot of physicians, I think, in my Facebook groups of physicians, they kind of poo-poo on these like, oh, these cash-based doctors, they want to be money grabbers, or people need to use their insurance. I was like, let's really break down what happens when people use their insurance. Because when people use their insurance, and I tell that person to go get their MRI using their insurance, they're charged $2,000. But if they went to my local cash-based facility, they'd only pay $500. Why that spread for the same exact service? Why? And I think because people don't know that you can actually access care and do it more affordably when we get insurance out of the way. So I started there to say that I think that we're stuck on this idea that insurance is the only way to access healthcare. And that idea is pervasive, not just amongst patients, but also amongst physicians who are like, what? your labs only cost $30. Like what? Like they just don't get it. They're like, how is that possible? At my physical, I paid over $500. So I think like giving these examples really help people see like we have a problem and we're all being duped when we overuse this form of insurance for things that we shouldn't be using it for. So I think if we take that framework and like help people understand what the problem is, now we can kind of bring alternatives for solutions. But I think when we lead with direct primary care, we lead with concierge, people are like, well, I don't think they see how it's solving a problem. I feel like they see it as an added cost, right? It's like, oh, you want me to pay more money for all this money and all this premiums and all this, and you know, so I don't think they can get it initially when you just lead with direct primary care and lead with concierge medicine. But I think when you step back and say, look at the bloat, you know, like it doesn't have to be this way, and here's how we can do it differently. So I think the first step is like recognizing we have a problem. I think people know that there's a problem, but I think they think, oh, that's just the way it is. There's no way that we can change it. You know, if you don't have insurance, you don't have care. And if you have insurance, all your care is covered. Like we have to change that conversation and really help people understand really the harms of insurance, particularly in the primary care space. And I had to educate myself a lot on that, you know, so like, you know, reading Matt's book, reading Dr. Macary's book, reading one of my favorite was Catastrophic Care. I can't remember the author of that. I'm sure Matt does or what if he does, but like really learning, it's like, oh my gosh, look how much we're spending, how little we're getting, and how much we can save if we can cut the bloat out of the system. So I say that to say we got to start the conversation with where the problem is, showing, you know, elucidating these examples of how using insurance can sometimes lead to harm. So I share those stories all the time about the difference in price when you use insurance versus when you don't. Make it make sense in that way. And then I think you can start laying the conversation for what is direct primary care, what is, you know, a cash-based practice, what is concierge medicine. I think that's the pathway we get there.
You just said two words that I've got chills. Make sense medicine, right? It literally, this all fiscally makes sense, physically makes sense. And it's just overall a much better system for everyone. And it's very sad. I mean, as a consumer, I'm in banking and finance. We have to disclose everything: rates, fees, upfront, signatures. Everyone is aware of what they're getting into when they take out a loan, whether it's a car, a house, a business. So to not have that on the flip side when it comes to, you know, I myself, I have a teenage son. We had 2 urgent care visits and it was astronomical when I got the bill, but we had no choice. So to have that choice would be, and just more education around it, I think a game changer, and we can really shift medicine in the United States.
Right. And it's making us less healthy because, you know, a lot of folks go with that, you know, fool me once, you know, shame on you second, shame on me. So a lot of times you're skipping their health care, right? You took your sons in and maybe they truly are sick next time around, but you're really going to think twice about, you know, can we afford to go back?
Also, I just have to say this from a financial perspective as a consumer. I think where the disconnect is hugely is direct primary care. You lay out the costs and they pay for that at the time of service. Am I wrong?
Well, they pay monthly typically. So they're paying like, it's like a subscription. I love using the word subscription because people understand that model. And that's kind of like the commitment between the doctor and the patient. It's like, you pay monthly, I'm available for you. You're not going to hear it's 6 months for your next appointment. Like that's your access.
Right. Okay. So they pay monthly. So they added up 12 months. It's going to be X, right? But from, you know, I currently have insurance, which I haven't used since I had to jump over to this extra insurance because I'm self-employed. But the situation from my husband got a hip replacement and I was flabbergasted. Like we had to show up at the time of service with $1,500 to give them right up front. And then 2 months later, I got a bill for $8,600, not expecting that at all. And I knew that there was going to be a percentage that was not covered, but I'm like, oh my God, you know, and that's something that the folks, it's almost like we have to hammer it. We have to constantly say it. From a marketing perspective, they have to hear it at least 7 times before it's ingrained in their head. You know, your paying a membership, but you already know what those costs are going to be. And comparative to you go pay your deductible or your copay, your $50 copay when you go in and have your primary care check you out. But then all of a sudden, if you have some extra tests, 2 months later is when you find out what your costs truly are. And I mean, I'm getting a little heated because it's just like you said, you don't have a clue. So,
and that's not fair. And I feel like people don't understand that until they experience it. And they're like, what happened? You know, I did everything I was supposed to do. I'm paying my premiums every month. You asked me to come with this big amount up front. It's hip surgery. So I understand it's not cheap. You know, I understand I'm going to put something down, but to get a bill that's over $8,000 a couple months later, that's unexpected. Just isn't fair, you know. And so I love that, you know, we have direct primary care, but we need more solutions. I know that's where people like Matt come in, of how do we take care of these larger expenses. Like the Surgery Center of Oklahoma has been incredible for that. We bundle it, you know. This is the price for your hip procedure. I don't know what it is, like maybe $25,000, which it's a big number, but that's it. You know, that's it. I was talking to one of my colleagues in orthopedics, and he's like, yeah, it's not fair. He's like, not only do our patients get billed, but they just keep coming. You know, it's like you get the OR fee and then the anesthesia fee and then the radiology read fee. And it's like, you just don't know when the stream is going to stop ending. It's like you get one big bill, you think you're done, and then they keep coming. You're like, when is the next one coming? And it's not fair. It's not fair. And I feel like when we think about consumer protection, this is where we need to protect our consumers, and it's been overlooked for so long. So I think we're at a breaking point, you know, just where we are in healthcare. Unfortunately, what happened with United Healthcare at the end of the year, I feel like it's coming to the surface about like where we have such a big problem. I hate that violence was a part of it, but there's been violence against patients forever in terms of the financial violence and the negligence and even just poor quality care that's being delivered at these astronomical prices. So I think telling these stories and people sharing their stories really helps us move the needle. And I think leading with, oh, here's another healthcare option and here's how much it costs, like it doesn't make sense until you understand what we're trying to correct.
Yeah, and these stories, unfortunately, they're right. They're not the exceptions. They're actually more of the norm. And it's just when it affects you, that's when it really hits home, because we don't need healthcare every day. But yeah, Keith Smith, the founder of the Surgery Center of Oklahoma, and there's many like that now across the nation, kind of that they've helped mentor. I think it's around 19. You can look right online and see their price. That's like just barely double of what you paid just for the deductible part. Crazy. Right. And Keith always says, right, do no harm, right? But he also says that means we take care of the patient physically, but also financially, right? We become complicit. I think many of physicians have started to use Demetrio. We talked to Dr. Demetrio in Nebraska, and he said, I felt complicit. Now, I was kind of ignorant before, I didn't know, and now I know. And so I need to maybe do something about this, because I'm not a robot. I'm not something they just plug into their money machine.
You are listening to Lifeboat for the White Coat podcast.
Do you have any words of wisdom? If you've been in their shoes, right? Do you have any words of wisdom for them, is from MD to MD, of what maybe they need to hear?
Thank you. Wow, that's a heavy one, but I would say that there's another way to do this. There is another way to do this, and it just takes us imagining something different. But I also say it to my colleagues, understanding the real challenges of getting from like the system into things like direct primary care. I think it's important for us to recognize how much power we have as physicians, you know, because in the end, people really have that trusting relationship with their physicians. I think people are waiting for us to come up with a solution to say, this isn't right. We have to stop doing this to patients. But the other hard part about that is physicians have been as much as victims of the system as everyone else, you know, so we've been strapped with this ridiculous amount of debt. I think the average medical student is walking out with a minimum of $250,000, but up to $500,000, $600,000 in loans. So to do that and then think to start up a practice and not get paid for a couple more years, like that's not realistic. And so we need more solutions and way to support each other, invest in each other, make this make sense financially, even to each other, so that we can heal ourselves financially and be able to deliver high level care. So I do want my colleagues to know that if you feel stuck in a situation, there's always a way out. It could be a little challenging, but there are communities out there that can support you through this, and we stand by you, but we do not have to accept the status quo. But to say like, oh, everybody jump on over, I want them to do that, but I also really understand the difficulty when you have put in this investment, when you have a family to feed, when you have to take care of your own expenses, like of how hard it is to make this transition. But I think if we don't do it, nobody else will, and we just won't have healthcare in this country, and none of us want to see that day. So I know that that's not like the perfect message, but I guess my message is like, we can do it differently. We have the power to do it differently. I'm not going to say it's easy. I think physicians feel like they're being disregarded or almost gaslit to say, oh, just go ahead and do DPC. Like people hate hearing that because like, it's not so easy. I don't know how to be an entrepreneur. There are practices that fail. That is the reality of it. But I think if we can be more cohesive as a community and really support each other and find investors and find ways to make this make sense, that it's a game changer. So I see a brighter day ahead. There's a lot of blood, sweat, and tears that are going to go into it, but it'll be so worth it to get out of the mess that we're in right now.
I think it's a great answer. And I think, and I certainly understand, right, there's kind of real life, there's our dreams and then real life. And, but when there's lots of resources, you can reach out to us and we can help you or get you to the right folks. Even MDs that have gone independent are often glad to help as within reasonable time limits, of course, but right. And this is a frustration of many doctors within those big systems. One thing I always used to say in HR too is, right, we say, well, it's a problem. It's not that bad of a problem. I'll just endure it the rest of my career. Let's see, how many years of work do I have left? Oh, 30. Wait a minute. Maybe we should do something about this problem. That's a long time. And it starts to just kind of affect our morale and our spirit, if you will, of, man alive, how am I supposed to extend myself and care for others when I'm being run over by a truck? So
because right now physicians are looking for a path out of medicine, and that scares me every day. And I don't blame them. But when I'm on my Facebook groups with physicians, like, how do I get out? How do I end this early? How do I do something non-clinical? How do I get out? I think we have that stat of 25% of medical students who are in school right now never intend to see a patient bedside, like they never intend to practice clinical medicine. So our shortages of physicians is growing exponentially. I think we're actually underestimating the shortage that we're going to have. So we have to find holistic ways to keep people in medicine that make sense for patients, for physicians, and for our communities.
Powerful stuff. The future is now. The future is not someday, right? The future is, I had a friend share this morning. So thanks again, Dr. Cooke, for your time. Certainly look forward to seeing this broadcast. It was an incredible discussion. Certainly wish you the best in your future as well. And thank you for all you do.
Thank you. I want to close on just one thing. Love your podcast. I do want to announce that I did a podcast about my DPC journey called Building DPC. And it's really meant to inspire doctors that are terrified of the journey, think that they can't do it. Because I said, I'm not a business person. I'm learning that every day. I try not to use that language because I'm learning this skill every day. But if there are other physicians who are looking for a doctor that's gone through it, and I really just go step by step. Why did I make the decision? How did I figure out my location? How did I choose my EMR? How did I do my marketing? Like I walk through all that in a 10-part series. And I find a lot of people have taken a lot of great inspiration from it. So just to highlight another resource that we have, it's kind of my gift to the DPC community to say I'm doing a very vulnerable thing, because it's hard to share what I don't know and like the stupid mistakes that I've made and the ones I'm probably still making, but it's okay to do that because it's for a bigger cause.
It's okay to try. And I think that you doing that shows that you have a heart to help, right? This isn't just a job for you. It's really about caring for people. And that's a way to help your peers as well. So thank you for that.
Thank you. Thank you all.
That sounds great.
We will post the link here, right as you guys are watching this. The link for her podcast series will be on here as well. And it's all about helping. All the doctors that we have interviewed, they're all like, reach out to me. I am willing to help and tell you what not to do to start off with and literally help your journey quicker than how I got here. This concludes this episode of Lifeboat for the White Coat podcast. Please make sure you visit whitecoatlifeboat.com.